Okay, so hello everyone, and welcome to the Clinical Psychology Today podcast. My name is Zara Walsh, and I am co-editor for the winter edition for 2023. So we are here today with Dr. Christian Moltu and Dr. Sam Nordberg, who are experienced clinical psychologists and experts in our topic for today, which is using measurement in psychotherapy. So thank you both for being with us today, and welcome.
Thank you.
Thanks, Sarah.
So maybe we could start with you both introducing yourselves, maybe telling us a little bit about your career to date and how you became interested in the topic of measurement and therapy. So Christian, would you like to kick us off?
Sure. Thanks. Yeah, I'm Norwegian, and I became a psychologist back in 2007. And from the get-go, I was interested in psychotherapy research on the one side and practicing psychotherapy on the other side. And after some years, I think that might have been in 2012 or something, I had a research project going where we wanted to find the points in a psychotherapy process where they kind of got locked in an impasse or the process was stagnant, and we needed a tool to discover when those instances were so that we could study them. And that really got me into this entire field of measurement-based care or clinical feedback or routine outcome monitoring, all the works. So since then, I've been building more and more research and building our own system even in that realm. Currently I'm a head of research at a hospital here in Norway. I'm a professor at the Western Norway University of Applied Science, and I have this research group that's directed at personalizing care in psychotherapy, but also beyond. So that's kind of my way into this field. Clinically, as a psychotherapist, I'm quite traditional, emotion-focused, trained by Leslie Greenberg, working humanistically with patients. Particularly, I like working with patients with anorexia and borderline personality disorder, which have been kind of my special interest in terms of psychotherapy.
Okay, that's great.
So I think that's me. I'll just pass the word over to Sam.
Yes, Sam.
Thanks. So let's see. So I started getting interested in measurement-based care during my clinical psychology training. At Penn State, the program runs an in-house training center that's also a community mental health center, and it uses measurement for all therapies every week. And I found it to be an invaluable tool as I was learning through many mistakes and much excellent supervision, sort of what worked and what didn't, what skills I needed to build and work on. And as I trained in cognitive behavioral therapy and then in psychodynamic psychotherapy, what I really liked was that measurement was theoretical, in that, you know, what you were measuring really helped regardless of which particular clinical theoretical approach you embraced. And so that really got me interested not only in measurement for my clients and for myself as a therapist, but also more broadly. And so at the same time, I was studying the effectiveness of psychotherapy, looking at a variety of different ways of statistically modeling change during psychotherapy. And the data that we collected was incredibly valuable in identifying, for example, what kinds of patients would rapidly respond to psychotherapy versus, you know, what kind of clients would struggle with psychotherapy or take longer to recover, and could we predict those things? And it really gave me the itch for building systems of care that had data at their core. So I also think about measurement, not just from the client and the therapist perspective, but also from the systems perspective, so that we can build systems that learn. And over the last sort of decade and a half, I've worked at the VA and then at two large what are called accountable care organizations, which are organizations with primary care and specialty practices. And there I've built out large integrated behavioral health systems supporting hundreds of thousands of primary care patients. And measurement, I think, is integral to building out those systems and supporting all the way from the patient and therapist level all the way up to the major decisions we make about our programs.
Okay, wow. So you both have that kind of direct one-on-one experience of using measurement as clinicians yourselves, but you've also both been involved in kind of overseeing implementations and the use of measurement by other practitioners. But you've both been very involved in the research on this topic over the last decade or so. So can you maybe, and you kind of alluded to some of this already, Sam, but can you tell us a little bit about the benefits that the research is showing that measurement has in improving outcomes and improving things like therapeutic alliance in psychotherapy and in psychological interventions?
Well, maybe we could divide and conquer here, because I think Christian has the real expertise on how measurement impacts the client therapist dyad, and I'm more focused on how it impacts systems of care. And maybe we could talk about it from these different perspectives.
Right.
From the perspective of systems of care, here in the United States, for example, and this is true in the UK as well, we have what many people term an access problem. Which is that clients have a very difficult time or have to wait for a very long time in order to access care. But with measurement, what I'm starting to learn is that maybe we have an access problem, or maybe we have a let's just send everybody to therapy problem, and we send a lot of patients into therapy who aren't ready or who aren't appropriate. And what we do is we set the client and the therapist up for failure by identifying the wrong patients and trying to get them connected up with a therapist. And so from a systems level, one of the things that I find the most exciting and the most sort of promising about measurement is it gives us another lens into identifying which are the folks who are going to do really well when we refer them into therapy, and which are the therapists who are going to do really well with different kinds of clients. And so when we start to be able to match better and filter better for really great matches, we can actually start to impact therapy effectiveness. And so we're starting to see some early work from James Boswell, Mike Constantino, David Krause, using the treatment outcome package, has shown the potential for matching patients, clients to the right therapist. I would say even more importantly at a systems level is identifying those clients who just might not really benefit from therapy. Because one of my greatest fears as an individual therapist is of somebody trying a therapy, engaging in a therapy, and not getting out of it what they hope, and thinking, well, therapy just isn't for me, or I can't get better, right? And if we can prevent that by identifying early on that now isn't the right time, or that this isn't the right intervention for this particular client, then we can sort of set aside that risk and perhaps give them the right thing the first time. So I'll stop there and let maybe Christian jump in.
That's great. Thank you.
So interested in listening to you, Sam, that I forgot the question. But the question is something. What's the meaning of this? What's the value of this on an individual?
What's the research showing that the benefits and the values are to using measurement in therapy?
Yeah. So one of the early findings that are important still is at the level of awareness or attention. One of the things that I think has been a problem in psychotherapy over time is I don't know what to call it, but it's you start doing something and despite maybe you have a sense or a feeling that this isn't the right, it's not going in the right direction, this isn't really helping, it's kind of like it's the thing you've started, so it's the thing you continue.
Right.
So one of the things that measurement helps with, and was the starting point for a lot of this research, is to alert the clinician, make them aware that something is not developing as expected for a patient with this kind of presenting problem here. And I do believe that only being made aware of something from outside the diet does something to the awareness, both on the client side and the therapist side, so that they have an impetus to really talk together. Like, how are we doing? Like, what is this doing for me? And so on, to be able to change direction if something isn't working. So one of the things that this could help us with is to actively assess and evaluate how the things we've started is working for the individual. And secondly, collecting data from a patient isn't like a passive procedure where they just give the information. They actively think, connect the dots within themselves when trying to respond to whichever questionnaire you use for this purpose, so that they are actually more empowered consumers of psychotherapy. They are being helped in communicating their needs, their problems, their resources, and so on to the therapist. One of the things that it has been very important to me, it was an eye opener when I went once to Sweden to be the opponent to a PhD defense, and the person had a study where they wanted to study people who had dropped out and been displeased with their therapist, and they had to cancel the study because they couldn't really get people to tell the stories about feeling misunderstood, because of they wanted to be nice to their therapist, who they saw as having tried their best to help them. So I was really attentive to how difficult it is for a person who is a client to communicate their needs. Like the power imbalance, the asymmetry is enormous, even though, like, tentatively we're all good people, right? But it's being a patient is so hard, and communicating when something is not working is so hard. So allowing patients, clients, to have a secondary route of communication into the diet from the outside, from the comfort of their own home, if this is administered digitally, is truly helpful. It's democratizing the therapeutic process, and that's also been very important. In fact, research does show that responding to the measure in itself outside of therapy has a therapeutic potential. So well-designed measures tailored to each client's needs increases the dosage of therapy that we manage to give in a resource-strained system. So I think it's expanding therapy into the patient's home, so to speak. It's been very important to me. And also what research shows is therapists and patients might more easily get to the point that matters, to kind of get rid of the detours and the talk about the other things, and really hit that mark of relevance for the individual patient. It makes it easier to personalize the treatment protocol to the individual's need there and then. I think that's one important factor.
Okay. It's really interesting actually to hear you both speak about this, because I think there's probably a misconception out there, maybe you'll disagree, that administering measurement is all about statistics and reports and justifying funding and things like that. But everything you've described from the research is very person-centered, matching clients to therapists, highlighting areas of concern for the client, giving the client a voice to feedback. What has been your experience of practitioners on the ground using measurement? Has it been that there are these misconceptions, or do you find that they kind of learn more through the measurement? What has been your experiences?
I think it's very helpful when trying to be part of developing a field, that you see your colleagues as they are, as very rational people. And when people say, oh no, clinicians are opposed to measurement, I don't think they are. What I understand them to be is protective of a potential helpful situation for the client, and they really don't want anything that's noise to that process to come in. So until they've understood that I can actually gain benefit from this with this individual, until they've experienced it, obviously some are reluctant to just accepting the research that this could be helpful. But in my experience, the reluctance, the carefulness, is before the exposure to using measures with an individual client. And when they see that the client likes it, the client feel that they can communicate by it, and they can actually get more information than they would have had, so they can understand their client better and talk more directly about the things that matter, that reluctance seemed to vanish quite rapidly, in my experience. So it's a before and after phenomenon at play here.
Right, I see what you mean.
Sam, how is that over in America?
Yeah, I mean, I'll add that in America, because we have more malpractice litigation and people practice defensive medicine more, another concern that clinicians have is that we will be collecting data that could later be cited or brought to light in a lawsuit. And so there are concerns around that. There are concerns around how the data are managed. And there are real concerns that some manager will use those data in some way to rank or penalize therapists. And I think that while that may be legitimate with some managers who may not understand the research very well, I think for people who really embrace measurement-based care and really understand how this works, that's not the purpose of measurement. The purpose of measurement is enhancement, not it's not punitive. It's not for the purpose of rating or ranking, because so much of what we do in psychotherapy is subjective, right? It's broken down to the dyad between the therapist and the client. And so, holding people somehow accountable to these data is a real implementation mistake. And so when really good implementations are done, these data are enhancements then and nothing more, right? They are enhancements. In my case, I spend a lot of time thinking about how the data can enhance a system, right? Improving how the system works. And then in the case of working and supervising therapists in those dyadic relationships, it's really about how can the data enhance that relationship. And there is a lot of power there, because we also know from research that some clients are really reluctant to bring up directly with their therapist some things that they may feel embarrassed about, for example, but they will do it on their phone, answering some questions. And then it's absolutely critical that the therapist make sure that they gently bring those things up in the session, because the client will be waiting for that, right? And so it's also, I think, really important to inform therapists that the use of feedback is a clinical skill, just like any other. And Christian has really impressed this upon me and has done, I think, a beautiful job of building out a lot around training around this notion. But feedback is a clinical skill, just like developing an understanding of, Socratic questioning or exploring, interjects or defenses. It is a technique. And we shouldn't expect to be good at it unless we get the appropriate support and training to develop that skill.
Absolutely.
I think that's an important point Sam is making, because it's when something is a measure, something is digital data collection, it's easy to think of it in technical terms alone. Like, if it's a tool, people often ask, does feedback work? Does routine outcome monitoring work? And obviously, it's not an agent in and of itself.
Mm.
The measure doesn't work in and of itself. It's how it's put to life by people, clients and therapists, that make it work. Like it's a hammer. It's not the carpenter in itself. So and I think that's so important, because to me, Sam, please help me. The person, our colleague who is researching deliberate practice and writing extensively about that, what's his name again? I forgot.
Tony Rosmanier.
Tony Rosmanier and a lot of colleagues wrote a brilliant paper, a position paper, more or less, called "Keeping Psychologists in the Driver's Seats," a couple of years back now. And I think it's very important because it communicates these values when it comes to what this information is for, what this data is for. As Sam says, there are numerous indicators, more or less tied to the actual clinical practice, being pulled and used for decision making on systems level. This is our professional content. Like it's the heart of the profession. It's the evaluation and process with an individual client that is usable as a data to inform decisions on a systems level. Meaning, for example, in Norway, we are counted on how many days from the end of a treatment to the end report is sent back to the GP. Mm-hmm. It's a perfectly okay indicator, but it doesn't say anything about the quality of the treatment that had been implemented just before. So now that we could have actual data from actual patients to inform decisions, like, are we indeed helping people with eating disorders in our clinic? Mm. We know that eating disorders are helpable based on research, but are we helping our clients? And can we use the aggregate information from our own practice to inform whether we need training of this or this or this? It's actually taking the professional discourse back into the clinic, and that's very important to me. That's what routines outcome monitoring can do. It can fill the system with indicators that mean something directly for the population that we are treating.
Mm-hmm, mm-hmm, absolutely. And it is, again, it's also more focused on the client than one might think. What has been your experiences of clients' feedback on using these measurement tools? How have they been finding it? How have they what do they say?
I mean, I'll start. I think we're going to probably say the same thing. Clients generally get on board with measurement that they feel is relevant to them, mm-hmm. And that they feel is used in the clinical setting. Mm-hmm. If they don't feel those two things, then you'll lose them quite quickly. But I think I often hear people saying, well, what about it's too much time. It's too much time for the client. I haven't run into that circumstance when the data are relevant and when they see the data being used in the clinical setting. They will spend 15 minutes, 20 minutes completing, questionnaires, answering questions that are relevant to them, that they then believe will be used in their care.
Mm-hmm. Mm-hmm. Not just kind of put into a drawer and never referred to again. It's when it's used and engaged with and referred back to by their clinician.
If it feels like someone is ticking a box,
mm-hmm.
then nobody's interested, yeah. Right? If it's just an administrative task that has nothing to do with the therapy itself, no one's interested, except for maybe the administrator who needs to tick that box. It has to feel like an integral part of care. Mm-hmm. But if it does, I think clients are willing to spend lots of time giving this information.
I agree. In short, like, patients not only are okay with it, but actually like it and prefer it when it's used for something to their benefit, which it can be. Mm-hmm. And I think it's important to be aware that when clinicians consider the potential of measurement, they kind of project something from within themselves over to the patient, that, oh no, the patients won't like it. But we've researched patients over time and they like it when it's used, and that is quite uniform, because it feels professional. Like when you go to, if you went to a heart specialist and they assessed you only by talking to you, but never actually listened to your heart or even took a picture of your heart, you'd be stressed. Like, aren't you going to collect some more data on it? Like, are we only going to talk? And it's the same, like if you're presented with a relevant measure, communicating that these are the issues that we take seriously here, these are the issues that might be relevant for you, that we invite into the conversation, that gives a sense of having come to the right place, having come to a professional place to be helped. I think that's very, very important.
And I'll add quickly, I think one of the places where clients find it the most validating is when the measurement shows that they're not getting better, and you acknowledge that in the room with them, and it validates their own experience, and it creates an open space to talk about that. That in some respects is actually more validating than noticing that they are changing and that the therapy is working. And I find that that's sort of one of those surprising things where the patient's spending a lot of time filling out the measure shows they're not getting better. Turns out that's actually a great time to be talking about the results of the measurement.
Right. And some of the research does show that measurement can actually work to improve outcomes more for population groups that are not on track. So kind of not on track cases, probably because of that phenomenon of bringing that into the room, acknowledging it, validating it, and kind of problem solving and going from there, really, isn't it? So I think for anybody who's watching this or listening to this podcast, mostly practitioners in mental health, we've used a lot of terms. There's feedback, there's routine outcome monitoring, there's measurement-based care. We all know there's so many different psychometrics and global measures and assessments that you can administer. What key advice would you give to practitioners who are listening to this, who are thinking, I do use measures, but I actually don't kind of engage with it that much in a way that might improve the outcomes or enhance the therapy? What can I do? What changes can I make to implement in my own practice that might allow me and my clients to reap those benefits that have been found? What advice would you give?
So Paul Meehl, who was a statistician ahead of his time, used to talk about valid for what, right? We have all these valid measures, these reliable measures out there, hundreds and hundreds and hundreds of them. But it's important to ask the question, what is this valid for? Is this a thermometer that just tells me whether or not my patient is feeling better or worse? Or is this more like a diagnostic that really gives me a deep understanding into some of the mechanisms underlying their challenges that I need to be working on and directly addressing? Because not all measurement is the same, right? So, you have measures that measure distress, like the PHQ-9 is the most commonly used measure in the United States. But it doesn't give you much more than just a sense of where their mental health temperature is, right? And then you have much more specific measures, ranging all the way up to like the MMPI-2, which takes far too long to administer in regular practice, right? But can be very, very detailed. And so I think clinicians should be asking, what am I trying to accomplish with measurement? And then think about, does the measurement I'm doing accomplish what my goals are? Because you need that match in order for measurement to really be relevant and useful.
I think that dovetails really well with a point that is being made over by many people these days. And Andrew McAlevey and we wrote a paper where we kind of defined the necessary component of using data in clinical practice is that you collect it routinely. It's not one-off, but it could be sessional, ideally, or every second session. It doesn't really matter, but it's a continuous thing that you collect it and look at it before a session. This is it's a banal point, but it's important that you are actually able to do something with what the patient is telling you, with their data in that session, and that you integrate it integrated in one form or another, make it actionable within the therapeutic process. And also the research, it started like research in psychotherapy often start with a horse races. You randomize and you control the feedback with the no feedback, and you kind of demonstrate the overall effect, and it's very positive because it's first generation. But then the research field matures, and it's always in a decade or two about what fits for whom when. And that's to Sam's point, what do you use it for? And current research, it's a beautiful little paper by Stephanie Brooks Holiday just now saying, yeah, it's about how you tell the patient what the rationale for using data is, and that you actually use it accordingly. Is that you invite the patient to be engaged in the visuals, to look at, yeah, you started here, but now you've come down here. What's happened? What have you done? What have you learned? What have you achieved to have this change in you, to activate it with the client? And that's not to say that if you're a cognitive therapist, you should put cognitive therapy on the side and work exclusively with measures. It's not that explicit, and it's not that much time you have to use on it, but it's to acknowledge it. And essentially, you asked if you were a therapist and you wanted to use it more, what would you do? One thing Sam told you, think about what's your rationale for using it. What are you using it for? And to involve the patient in that rationale. Ask the patient, yeah, I want to use this measure to learn more about whether what we're doing is working. How do you experience filling it out? What does it mean to you? Just start the conversation. And that's the part of the thing that's the clinical skill. It's just asking, exploring, being curious on what is the patient trying to communicate when they are responding to the measure. And that's easier with a clinically relevant measure than with a ultra short diagnostic depression tool, like, for example, PHQ-9. There's more things to talk about, so to speak.
That's great. So it really is about kind of knowing what measure you're using and why, bringing that rationale to the client and using it to collaborate through the therapy. Because as you said, using measurement in itself isn't a therapy. You're still a therapist with all your training and everything, but you're using this as a tool with your client. So that's all. That's
and it's
really
not authoritarian, like sorry, Zara, I just wanted to make your rationale for using it might be different than mine. Your ways of working might be different than mine. And I need to tell my clients why I'm using it and what they can expect from me in relation to it. And you'd, according like to your own practice, you'd tell them how you were going to use it and act accordingly. And that's personal. It's not a one size fits all in this realm.
Absolutely. Great. So look, we're gonna round up now in the next few minutes. But I just wanted to finish by asking you both where might people find out more information or read a little bit more if they're interested in this topic?
Sam?
Sure. So let's see. So if folks are interested in how measurement is being incorporated into the work that we're doing in the organization that I currently lead, Behavioral Health, there's a great paper out from Sue Yoon that describes our sort of ongoing initiative to look at augmenting treatment offerings with digital therapeutics. And we've built sort of a learning health system that allows us, using measurement, to really look at not just overall what works for whom, but to break our patient population down into subgroups, precise subgroups, and look at each subgroup and say, well, what does this subgroup need, right? Getting back to this quote from Paul Neal, right? Valid for what, right? Well, each subgroup has different needs and different things that are going to be helpful and valid for them. And so, I'm most excited right now about this work, creating learning health systems. And therapists can do this in their own clinical practice, turning your own clinical practice into a learning system with the right measurement. And so that's the work that I'm sort of the most interested in, that I certainly would ask people to take a look at, because I think it really does offer each of us the opportunity to turn our own system into this sort of like growing, learning healthcare system.
People want to read research papers. There's a lot of research papers coming out of this group now. They could kind of look up my name on Google Scholar or something, or visit the Norse Feedback Routine Outcomes Monitoring Internet site, the homepage. I would also recommend quite a recent book by Kim de Jong, a Dutch researcher, a colleague of ours. She is eminent in her approach to clinical feedback and routines outcome monitoring, and she recently published a clinician-friendly, comprehensive book on using feedback. And maybe if there are resources tied to the podcast, you could link to that book. I really recommend it.
Yeah, that's Kim de Jong, Delgadillo, and Barkham, isn't it? Yeah, I think I read that recently. It's a good book. Yeah.
There's also sorry, just quickly, there's also a terrific article in The Atlantic by Tony Rusmanier. Many folks may already be familiar with it, but it is a fabulous sort of therapist's perspective primer on why should I do this? Why should I even do measurement-based care at all? That's a terrific sort of first-person article.
I think it's available as an article and a podcast, actually, so it's definitely worth checking out. So look, we're coming up to time now, so I just want to thank you both for being with us today, and best of luck in your research and everything in the future. So thanks very much.
Thanks for having us, Sarah.
Take care.
Thank you. Bye now.
Bye.